Well, hello, everybody. My name is Dr. Justin Dumont. I'm an interventional pain physician at OrthoVirginia. I'm located in Richmond, Virginia. Today, we're going to talk a bit about using spinal cord stimulation and neuromodulation to help address chronic pain conditions. A little bit about me. As an interventional pain physician, I provide a number of different treatments and solutions to try to help patients who are dealing with pain. Many times we use, injections, but sometimes we use other types of procedures like spinal cord stimulation. I'm sure we've all have heard about chronic pain. It's been widely publicized over the last 10 years, especially in light of the opioid epidemic. But chronic pain is pain that is persisting for long periods of time. It can be exhausting. It can be debilitating for many folks. It can really impact quality of life. With the emergence of spinal cord stimulation many years ago, we've had an expanded arsenal of treatment options that we can provide patients with very specific types of pain. Spinal cord stimulation treats pain, which is typically we call it neuropathic pain or nerve pain. It's technology that's been around for many years, and there has been many advancements over the last 20 years, and there continue to be advancements that are taking place now. I like to describe spinal cord stimulation as electrical medicine. What does that mean? We use a safe amount of electricity to stimulate parts of the spine and nerves to help treat pain. How does that work? And oftentimes people will ask me. Well, in the spine, we have certain areas where information and painful information is sent to the central nervous system in the spine. And by placing some leads over these areas and sending a safe amount of electricity, we can change or alter how the pain signals are interpreted by the body. That's why it's called neuromodulation. The typical spinal cord stimulator system involves three parts. Okay, there are the leads, which are small little leads that are placed into the back part of the spine. They're typically placed in what's called the epidural space, which is a safe place where we can place these leads. This is the same place that we use sometimes when we do certain types of spinal injections. These leads are placed in the back part of the spine, kind of in a fashion like this. They're done through a needle and they're placed into the back part of the spine, in between the bony part of the spine here and the spinal cord. There are other types of stimulator systems where we can place leads over where the nerves are exiting here, in these little bump areas as well. But when we place these leads in, we don't just place them there. We connect them to a battery, and these are called an IPG, okay? And here are some examples of the batteries and typically the size of them. What does this do? So once the leads are in place, we connect them to the battery unit. And this has hardware and software built into it that we can make some customizations and some programming done through the use of an external device, which interfaces with the battery, okay? So the external device will have some options for the patient to make some changes and adjustments to it, and it communicates directly with the battery unit through oftentimes Bluetooth and those types of wireless technology. So what does that allow us to do? That allows us to program very specifically different types of treatments that are tailored to the specific type of pain the patient has. So you'll see, oftentimes, there's a lead here. You can see there's individual little contacts there. These contacts, we use them to help to send electricity between each of the different contacts. So there's many different possibilities about how we can program it to really tailor the treatment for the patient's need. Oftentimes, when we're replacing these leads in, what we do is we really target certain areas of the spine where the patient may have types of pain. So it's not a one-size-fits-all. oftentimes we may have to tailor if it's more right or left-sided, or if there's more back pain or leg pain. But the ultimate goal is to really try to make a tailored solution for the patient and give them options. And that's really where the handheld devices come in as well. As patients are given these options to have different types of programs based on certain things they may be doing. The treatment, again, we talked about, we use it typically for what we call neuropathic or nerve-type pain. There are several major types of pain conditions that we use spinal cord stimulation to treat. Okay, I'm going to walk through those briefly here. The first is a condition where someone may have had back surgery or prior spine surgery, and they may have persistent back and leg pain. Spinal cord stimulation is a great option for this. The term for this type of pain has evolved over the years. It's been called post-laminectomy syndrome. It's been called failed back syndrome. We currently describe it as chronic spinal pain syndrome. And spinal cord stimulation is an approved treatment option for this type of pain. Another type of pain condition that we use spinal cord stimulation for are for other neuropathic pain conditions, such as chronic radiculopathy. So meaning some folks may have a radiculopathy, meaning that's a nerve root irritation that's caused some chronic pain to go down into the leg. We use spinal cord stimulation to treat that as well. Also, we use spinal cord stimulation to treat conditions with painful diabetic neuropathy. That's a condition where the diabetes and the blood sugar are elevated, and it can cause some irritation to the nerves, especially into the lower extremities. And so this is an approved treatment for that as well. We also will use it in some certain types of cancer-type pain, or say folks who maybe had chemotherapy and they have some neuropathies associated with that. That's also another type of treatment or another type of diagnosis that we use spinal cord stimulation to treat. There's also value and use for using spinal cord stimulation for other types of post-surgical pain. I will oftentimes consider this for folks that may have persistent pain after total hip or total knee replacements. Some folks who may have chronic abdominal pain after maybe multiple abdominal surgeries, and even pain after amputations as well. That's another indication. There's also a condition called arachnoiditis, which is a scary sounding word, but it's basically a painful irritation of the nerve roots in the spine. And that can arise from various causes, but frequently it's found after some surgical changes as well. And finally, one of the primary diagnoses we use spinal cord stimulation for as well is a condition called complex regional pain syndrome. And it's a diagnosis that's made by a physician, and it's usually there are certain signs and symptoms and clinical findings that we see that lead us towards this diagnosis. And at a high level, it's a condition where someone may have had a trauma or an injury or surgery to somewhere in their extremity, and they may have some severe persistent pain and some changes to some of their extremities, whether it's swelling or edema or skin changes that have a very unique appearance. And so spinal cord stimulation is another great treatment option for that as well. Oftentimes when I see patients that come in, they often will ask me the question, well, who's the right person? What's the right candidate for spinal cord stimulation? And I oftentimes will have a conversation. It's not a one-size-fits-all. I oftentimes try to really get in a sense of really what's been their history. I oftentimes will look at their prior imaging or maybe order some further imaging. I'll look at medications and things that they've tried. This is a treatment for chronic pain. So meaning folks have tried a lot of different things and they're still having pain that is severely impacting their day-to-day activities, their quality of life, and their function. We talked about some of the key diagnoses, but again, sometimes some folks may have these diagnoses, but maybe spinal cord stimulation isn't the right fit for them, and that's really the value of the relationship that I build with my patients is trying to understand who are the right candidates for spinal cord stimulation. One thing that I like to tell my patients about spinal cord stimulation is that what makes it unique is that it's one of the very few things in medicine where we can try the treatment before we actually implant it permanently. So let's talk about that a little bit. When we're considering someone for spinal cord stimulation, after I review information, I examine the patient, I talk with them, we try to do a level of expectation setting about what's their goals, how's pain limiting them, where's their pain, and try to get a real clear sense of what's the pain that we're treating. We'll often send folks to a psychological evaluation, which is part of the process as well. That's done. Typically, most insurers require us to do that, but I see great value in doing that as well because we also want to make sure, like I said, can be exhausting. Sometimes there's some depression and anxiety that can come along with it. We want to make sure that we're treating the whole person. So the psychological evaluation is part of that process. But after we go through that, then what we typically will do is we'll talk a little bit about the process and we'll schedule them for what's called a trial. Okay, so what's a trial? A trial is where it's done in an outpatient setting, admitted to the hospital typically for these types of things, where the patient will come in, we'll have them lie down on the procedure table, we drape everything, it's all done under proper precautions. But by using a special needle, like we talked about, I will place some temporary leads into the back of the spine and connect them to a temporary battery type unit. You have to fix to their back with some special tape and some little special pouch there. We give folks a period of time, typically less than a week, to really understand how much the treatment can help them. During that time, the patient will work together with the vendor from the company that we're working with and make adjustments throughout the course of the week. The goal is to understand how much it helps, right? And we don't want to do something just to do something, but we want to really get a sense of how much the treatment can help someone address the pain that they're primarily finding as a limitation to their day-to-day activity. And then we reconvene at the end of that trial, and we take out those temporary leads and we have a conversation. The focus of that conversation is really to get a sense of how much it helps you. And it's not so much just the pain relief that we're looking at, but we also look at other questions. For me, I really like to understand how was their mood during the week? Did they see improvement with mood? Did they see improvement with sleep? Did they see improvements with some of the key things that they may find limits them with? Knowing that there's obviously it's a trial and it's temporary, but it gives us a sense of how much will this or can this help with the pain that they have. And we get a sense of percentage of relief. This is one of those things that shouldn't be, I think it helped me. We really want to have a conversation and say, no, it helps and it helps me in these ways. And so the goal of that meeting, that follow-up meeting, is to really walk through the percentage of relief and functionally, where did we see improvements? And then we have a shared decision about, is this something that we want to consider implanting permanently? Okay? So we talked about the three parts of the stimulator system. As we move towards the implantation process, what we do is we place the leads typically back through, and sometimes we may use another type of lead, which is a paddle lead that will place into that area. With the assistance of a surgeon. But the goal is to place the leads back in the same area we were before, tunnel the little wires through the skin into the back, and then place a battery, it's like a pacemaker battery, into the back part of the lower back or in the buttock region. Then connect those wires and bury those wires underneath the skin. That entails the implantation process, okay? So that typically is an outpatient, same-day type procedure, surgery done. people are not routinely hospitalized for that, and it's typically an in and sometimes folks may receive some sedation or possibly general anesthesia for that, just to help keep them comfortable. So that's typically the process of how it works, right? I would strongly encourage you, if this is something that you're considering, you may want to, if you're in the Richmond area, I'm happy to see you and talk to you about this and see if you may be a candidate, or if you're outside in various parts of the state. We have wonderful interventional pain physicians in OrthoVirginia that would be happy to help with you or help discuss your case as well. But this is really something that you need to have a conversation with a trained physician on. And as an interventional pain physician, this is something that's a core part of my practice. This is what we do. The nice thing that I like to tell people is that this is a great treatment for treating that chronic pain. The goal oftentimes too is to really understand if we can also help to reduce some of the use of other medications, right? So those are some things that we look on kind of after things have been implanted. Once it's implanted, we look at functionally how things are improved, if they've had a reduction of medications, and the goal is to try to use the therapy to its fullest so that we can minimize some medications and those types of things which may cause side effects, right? I'm just going to go over a couple of frequently asked questions. I'm getting a question here. Are they permanent? Yes. Okay. And how long is it? Yes. Those are frequently asked questions I will answer right now. A question I often am asked is, well, if I have this implanted, is it going to limit me from having any imaging in the future? Okay. I know oftentimes with pacemakers and such, there may be some limitations. There are, and again, you have to check with the types of systems that are being selected, but there are systems out there that have them compatibility, and oftentimes, we'll use those types of systems so that people can continue to have CT scans or MRIs. Obviously, with some limitations, there's some compatibility. Oftentimes people ask me, can I exercise? Can I do my normal day-to-day activity? Sure. During the trial period, we do place some limitations on certain types of activities, just because these leads are temporarily placed in there, we don't want them pulling out. And during after the implantation process, we do put some limitations for a period of time until these leads will scar down in that epidural space. So there are some temporary limitations, but after a period of time, the goal is, yes, let's try to resume some of the normal activity, some exercise, swimming, those types of things, because we want people to be active. That's part of the goal here, right? A question I'm also frequently asked is, am I going to beep when I go through an airport or an airplane, right? And yes, you may. Everyone receives a card, okay, that says that you have the device in place, and that I often encourage my patients to bring that with them if they are traveling. The question that was asked over here, what happens? Is this a permanent system? These systems can be removed if we find that maybe it's not providing the relief, or maybe the pain has changed, or it's no longer needed. But yes, they typically can be removed. The other question that was often asked to me is, what are some of the potential complications, right? So we're dealing with we have little small leads. In some situations, sometimes these leads may migrate and move. And that's typically a discussion if that's happening, that's typically a discussion that'll take place between the physician and the patient to figure out, okay, has something changed, and that may warrant some further imaging just to ensure that things haven't moved. These leads are, very small leads. And so, again, sometimes there are situations where there may be some small little fractures of the leads. These are rare, but these are possibilities, things that I like to talk to patients about. Okay. Sometimes, if that is the case, sometimes we just replace the lead. Okay. The other question I get often asked is about people that take blood thinning type medications, and oftentimes that is a discussion that we'll have to have with a prescribing doctor. During the trial period, I frequently ask patients to hold certain blood thinning types of medications, and then when the system is implanted as well. We usually work through a shared decision-making process with the prescribing doctor to make sure that we're not appropriate, or we're appropriately holding medications if they need to be held, or not holding them or withdrawn. So those are typically the common questions that I get. Again, I would love to, if you have questions specifically about, is this a right treatment for you? I'd love to see you. If you need to make an appointment, and if you're in the Richmond area, you can do that on the MyChart. If you have our MyChart, you can set up an appointment with me, or you can call our call center, or you can call our office directly. If you're not in Richmond, there are other physicians throughout the state and North of Virginia that are skilled and capable of doing that. So after today's presentation, in the next couple of weeks, we'll develop a blog post with some of the key salient points here and answers to some of the questions. So please be on the lookout for that. Again, thank you for your time today. Hopefully we answered most of the common questions that I often will answer for patients considering this. Again, it's a wonderful treatment option for the right patient. So thank you for your time. Have a great day.
Thank you, Dr. Dumont. We have some questions that have come in. So does Medicare cover this, or other insurance? Is it an insurance-covered therapy?
Again, we talked about the indication for it. There are certain diagnoses that are appropriate. It is covered by Medicare. It is an approved treatment for the chronic pain conditions that we discussed. Private insurers also cover this as well. We did talk about the one piece that has to be done typically is that psychological evaluation as well. And I think it's a valuable piece. So that is another factor that is also required, but is also covered as well, typically by most insurers.
Thank you. How is this similar to or different from a TENS unit?
Sure. So a TENS unit uses little pads that are sticky pad type things that are placed onto the muscle, and that's done through the skin, and it innervates some of the muscles of the back. Spinal cord stimulation actually sends electrical signals over the nerves, so it's different in that it's not done just through the skin, like transdermally. It's done inside the body and stimulates some of the deep nerves around the spine. So that's a great question. I often encounter that. It's different, and the indications are typically different. I typically will, refer patients to the TENS unit if they have, say, muscular type pain. This is a treatment for nerve pain.
Thank you. Are you able to give some examples of diagnoses that maybe a spinal cord stimulation may be appropriate for?
Yeah, sure. So let's recap the typical most common ones. Folks that have had chronic persistent back or leg pain, and if there's some sort of spine surgery, that's typically called post-laminectomy syndrome, chronic spinal pain syndrome. There's also chronic radiculopathy. There's myelitis. This is another treatment. Diabetic neuropathy.
Can you repeat those a little louder, those last couple, please?
Sure. Painful diabetic neuropathy, chemotherapy induced cancer type neuropathy pain. There's also chronic pain conditions such as pain after amputation, or chronic abdominal pain after abdominal surgery, or chronic persistent pain after hip and knee replacement. And then the other major diagnosis is complex regional pain syndrome, which is a constellation of signs and symptoms that lead us towards this diagnosis, which is a very unique diagnosis made by a physician. Thank you. I sure appreciate your time. Thank you for taking some moments out of your day. Again, I'm happy to help if you have any questions.